right, everyone. Thank you everyone for joining. My name is Matt Bobel, and I'm one of the leaders of the Colorectal Surgery Virtual Education Series. And before I introduce our topic and speaker for this evening, I want to make a brief plug for our upcoming American Board of Surgery mock oral board exam session on November 6th. We are still looking for 2 tribute examinees for that night. Each person will be given 2 colorectal scenarios and then receive feedback. Please reach out to us via email, Twitter, or Zoom if you are interested or if you know someone who would be interested. Now, without further delay, I'm thrilled to introduce Dr. Rahila Essani, who will be discussing how a robust enhanced recovery pathway can enable same-day colectomy. Dr. Essani is a double board certified colon and rectal as well as general surgeon. She completed her general surgery residency at the University of Rochester in New York. During residency, she did research in colorectal surgery with Dr. Robert Baert at the University of Southern California. After residency, she spent a year in colorectal simulation research and then underwent advanced rectal cancer management and minimally invasive colorectal training with Dr. John Marks in Philadelphia. Dr. Essani then completed the ACGME accredited colorectal fellowship in Columbus, Ohio in 2011. She is currently practicing at Baylor Scott & White Healthcare in Temple, Texas for the last 10 years. Her main interest is minimally invasive rectal cancer surgery and robotic colon and rectal surgery. Our topic tonight has generated robust conversation on Twitter regarding the implementation of same-day colectomy. So far, of the over 100 people who completed our poll, 20% have incorporated same-day colectomy into their practice, and another 50% of respondents were interested. I'm excited to hear about Dr. Essani's experience of incorporating same-day colectomy into her practice. The floor is yours.
Okay, so thank you, Matt, for inviting me. Sorry for, it's always a little bit of troubleshooting. So less than 24 hours or ambulatory colectomy, as you mentioned, there was a robust discussion on Twitter just for the past 2 days. When I started this in 2020, it was in response to COVID surge and the shortage of hospital beds. When I started it in 2020, it was consciously starting it. Subconsciously, I've been doing it for the last couple of years, sending patients home within 24 hours after surgery. So is it really a thing in colorectal surgery? That's my slides. So are you kidding me? No, really. And you can see from the response on Twitter, these are my disclosures. So I characterize ERAS and same-day colectomy or less than 24-hour colectomy is life before COVID and then life after COVID. So traditionally, colectomy patients were admitted for 1 to 2 days, particularly on my service. Milestones for discharge were bowel function, gas or BMI, bowel movements, ambulation and pain control, and diet tolerance. The length of stay was shortened due to an already robust ERAS program, which from 2019 to 2020, I noticed that my patients were going home sooner and sooner. And this is from little tweaking in the ERAS program, doing things, and I'm going to talk about more what ERAS has really done for us. So the robust ERAS, anybody who's thinking about doing same-day colectomy or decreasing their length of stay, a robust ERAS is a must. If you don't have resources to have a good big infrastructure, it's still important to have a protocol and a standardized protocol and treating all the patients the same way. When I was a resident, we were keeping patients in the hospital for 7 days, sometimes 11 days. Especially open surgeries. And now open surgeries have their length of stay has shortened as well. And then MIS and particularly nodes extraction has decreased with the smaller incisions, has decreased the length of stay to merely an hour, merely hours right now. So a little bit about me, my cases from 2017 to now, I've done 639 major colon resections. Mostly initially experience was laparoscopic and then close to 500 robotic colon resections now. I do mostly all my patients with intracorporeal anastomosis. It doesn't matter, is it right or left or ultra low anterior sections. And then some colostomy takedowns and some left colectomies or total colectomies. So life with COVID. So 2020, we got hit by COVID, and New York saw a big surge. They were shut down for 4 months. Texas shut down initially during mid of the year, and then December 2020, I had what I like to call patient zero, who gave me the push to actually consciously make a decision to send the patient home hours after surgery. So first planned async colectomy, we had, as I mentioned, bed shortage. This was actually a planned robotic ultra-low LAR with diverting ostomy. It was a coloanal. This was a 67-year-old gentleman who had finished his chemoradiation. He was at 8 weeks post chemoradiation, and his surgery had already been canceled once because of COVID. So, 2 days before, when I found out we didn't have any beds and we may have to cancel his surgery one more time, and keeping in mind that I already noticed I had shorter length of stay, I spoke with him about going home, or actually in his case, because he was from an hour away, going to a hotel across the street. Long story short, his surgery went really well, and I'm sending him to the hotel within 6 hours with a Foley catheter. This is him, and this is shared with the patient's permission, sitting in my clinic at 8 a.m. next morning, and he's getting his ostomy teaching. You can see the ostomy teaching kit, and he has his water jug with him when he's keeping hydrated. So after the surgery actually had really gone well. We had EBL of 50 cc's. I checked labs on him and then sent him to the hotel. I gave him a dose of DVT prophylaxis, and his IV was removed. And he was advised to actually take full liquid diet when he advanced himself in the hotel. These are his incisions, so you can see it was truly an ultra-low with a diverting lobaliostomy. This is his specimen. Essentially, all of his rectum was removed, so this was a coloanal for rectal cancer. And this is him kind of showing me his ostomy next day at 8 a.m. So what about the feedback I got from him, and this is in a year and a half later when he told me how he felt and what he would do if he had to do this all over again. So immediately he told me he had uninterrupted sleep. If given a choice, he would do it again. He loved sleeping in a hotel bed, which he thought was more comfortable than a hospital bed. And he had brought some home cooked meals, and he actually came to the hotel with his brother.
During the first surgery as outpatient, we were facing delaying your surgery. How did you feel?
I didn't want to delay the surgery. If I'm not mistaken, I'd already pushed it back one time, and the delay was based on a surge of COVID.
So this is the patient's perspective of telling me that he didn't want to cancel his surgery because of COVID. And when we talk about patient's perspective, we also have to think about how do we incorporate patient's decision in this? And this has to be a shared decision. This was a decision between him and me. We made it together. When I talked to him, I talked about either canceling his surgery, rescheduling it, or we go ahead. And he said, if you're game, I'm game. So we proceeded with his surgery. All the videos in this talk are shared with the patient's permission. So I was really proud of myself. Wow, I sent a patient home after a robotic ultra-low coloanal. So I posted it in social media. Some of the feedback I got was attention seeking, chest thumping. Some people thought I was committing malpractice and using COVID as an excuse. But the real crux of the mess was, what about future reimbursement? And that's the real question. And I'm going to address that in a little bit further along in the talk. What about future reimbursements? So lessons I learned from my first case: patient selection is really important. This is a 67-year-old, very aware. He plays basketball. He's very healthy, and his comorbid condition, he only had hypertension. Age is important. My cutoff right now is nobody over the age of 75. And then fitness level is important. He plays basketball. Obviously, a patient who comes in a wheelchair and has CHF or AFib is not going to be able to go home. And then looking at comorbid conditions. So when I gave a talk about it at SCARS, I did a poll on, do you do say on Twitter, same day colectomy? And 71% of the respondents said, heck no. And the follow-up poll was, so what is the reason? If you're not doing same day colectomy, what is the barrier? So surgeon concerns, the biggest concern actually was lack of infrastructure. 47% of the respondents felt they didn't have enough bandwidth or hospital support to be able to send patients home. Then followed by surgeon concerns, patient concerns. I don't know how we can address patient concerns without talking to the patients themselves. And then reimbursement and financial. When I posted this on Facebook, on a robotic collab group, there were people who were interested to hear about it. And then they would like to, or they're trying to. So need a guidance or a guidelines versus an infrastructure to do that. And then follow up to that poll was, what are the perceived barriers? So again, certain concern, hesitancy, extra work for them and their staff, and then reimbursement. So we keep seeing the same theme over and over. So this was the poll just 2 days ago, which talked about, have you incorporated ambulatory or same-day colectomy in your practice? And so we noticed that the percentage of respondents has gone down with no, not yet, so from 71 to down to 50%. And then there are additional 30% who don't think they actually can ever send the patients home. These are some of the comments. I kind of was browsing through Twitter while I'm working on my SAGES abstracts and stuff. One person felt that there's an increasing intention to put OR times and hospitalization days as quality measures. The shorter, the best. But I think the only outcome measure should be patient safety. I agree. The only outcome should be patient safety. And OR time, hospitalizations days should not be quality measures. These are short-term outcomes. And if, as colorectal surgeons, we do oncological surgeries, and oncological outcomes are the most important. But patient safety can be mitigated. The question of patient safety or concern about patient safety can be mitigated by having an actual inclusion-exclusion criteria and having an algorithm and a protocol to follow. Not everybody can do it. I want to keep repeating it over and over. It's not for everybody. You have to have extensive support to do this. Patients, there was another person on Twitter who felt the patients feel pressurized into same-day colectomy. Profits often speak louder. If you talk to my patients, and I'll have more patient videos, my patients don't feel pressurized. From the onset of seeing them in the clinic to the time they're discharged, they've given multiple points at where, if they choose to, they can stay in the hospital. The goal is not for us to force these patients out of the hospital. The goal is to, if they are comfortable, they can go home. If they're not comfortable, they can stay overnight. And again, the goal is to avoid ED visits. If we, the whole purpose of is to send patients home, we don't want to overburden the ED by having them come back in if they're not ready to go out. So, and again, and another one of, oh my, insurance are drooling at the prospect of no longer paying inpatient rates of a colectomy, more profits on the horizon. Well, we were sending patients home 7 days later after colon resections 10, 15 years ago. We cannot stop progress just because we're concerned we're not going to get paid. We are getting currently paid, and this may change in the future, and it's hard to forecast that, but we cannot be petrified of making progress just because we're not going to get paid. And I think really the crux of the matter is going to be if the hospital reimbursement is going to be down. The CPT codes are not going to change. We're using the same inpatient CPT codes for these. The patients, as of now, the hospital is getting reimbursed. What future brings, we will see. But it's for us to then fight these changes because these patients are going home. does not mean the complexity of the case or the complexity of care has changed. We have just changed the setting of the patient care. So one person said, you're clearly working with different patient population, mostly ASA 2, 3, 4, obese and multiple comorbid locally with significant social difficulties. No chance they could go home as a day case. In my colectomy population, there's my patients, there are only 10% of them I'm sending home. They are highly selected. So anybody who discounts that and they say, well, my patient population is different than yours, they have to look at the criteria, and you will find everybody has this 10% of patients who should be able to go home if they're ready and you're ready. Then there's another person who felt that while I have sent many patients home less than 24 hours, don't have the infrastructure to feel comfortable with same day. Plus, if it were me, I wouldn't want to go home day of surgery. We'll get there though, probably. Again, it's going to be addressed with patients talking about how they felt, and not just when they were in the post-op, but also next day how they felt and if they would ever do it again. Then there's some concerns about hernia, SBO recurrences. I think the point is missed here that all of these are MIS colon resections, in my hands, robotic colon resections, and with nodes extraction. So the incisions are minimal in these patients, and we do other things to mitigate pain control and hernias and recurrences. Well, not recurrences, but hernia and small bowel obstruction. So infrastructure or extra work for these patients. So our health system has a dedicated work group. It meets bi-weekly. We make evidence-based changes to our ERAS protocol, which looks at current literature and our own outcomes. And we change the protocol based on our outcomes, also on feedbacks from groups and hospitals. So what does it take to make ERAS successful? The take home I want for the colorectal fellows from this year, people who are coming out in practice, is not that, wow, it's easy to do. We're going to do when I get out in practice and I can do it. You have to work towards it. And so what does it take to make ERAS successful? First of all, it has to be patient-centric. And this is what's lost in social media and Twitter, that this same-day protocol is patient-centric. The patient has the most important buy-in in there. This protocol, in my hands, does not move without the patient buy-in. Then hospital administration comes into play. My office staff identifies these patients, make their various appointments. We make sure they have a good social system at home, social support, nursing staff. My ERAS nurse tags these patients, and then we have an ERAS class we run, and we reiterate about going home, and we're going to be there with the patient every step of the way, so they feel supported. Anesthesia comes into play with minimizing narcotics in the operating room and fluids in the operating room. PTOT, if the patients are need rehabilitation, they're advised to exercise 30 minutes a day, and we will get them in touch with physical therapy. Pain service comes in the play for ERAS protocol, whether for a TAP block, be it in pre-op, intra-op, or post-op. And then, so it really does take an entire village to make it successful. And the surgeon is the chief in place who kind of runs this team to make it successful. So what about unpredictability of who will have complications? Potentially avoided by strict inclusion-exclusion criteria. So the message I have is not all of your patients are going to be same-day colectomy. Obviously, an 85-year-old with CHF AFib is not going to go home, or a 45-year-old malnourished with prealbumin of 1.9 is not going to be able to go home either. And the surgery has to go successfully as well. So after my first few cases in early 2021, we actually formalized the same-day protocol and came up with an inclusion-exclusion criteria for our same-day colectomy. It's published in Baylor Proceedings as our first few patients experience. So partial colectomies, candidate for laparoscopy or MIS, or in my hands, robotics. Less than 2 or less than 2 simple comorbid conditions such as hypertension, diabetes, patient age less than 75. Initially, we had picked patient age at 65, but then we realized patients who get cancer, they are older, and although we're seeing them younger and younger, and they have to have adequate nutritional status. So I don't check nutritional labs, but if they give me weight loss history, then we will get pre-albumin or albumin levels. Exclusion criteria: a history of severe cardiac conditions, arrhythmia, heart failure, and more than 2 simple comorbid conditions. So this excludes everybody, cirrhotics, all the others. So simple hypertension, diabetes, obesity, obstructive sleep apnea, something like that. We calculate frailty score for all of our patients. Frailty score, for people who don't know what it is, it looks at patients' age, hemoglobin levels, grip strength, and ASA level. And patients who don't have home support. So when I identify these patients, same-day patients in the clinic, my second question usually is, who is going to be at home with you? Do you live alone? Is there somebody who can stay with you? Is there somebody you can go stay with? Or how far away are you coming from? So for us, a same-day protocol is 3 phases: preoperative, operative, and postoperative. I can't emphasize the importance of preoperative phase of this. The patient has to be prepared, and the patient has to be mentally ready for this. Otherwise, this is not going to work. So preoperative, again, patient buy-in is the most important. Every time I see a colon resection, first, when I see them in the clinic, on my schedule, I've already identified a patient who's going to be a potential same-day patient. And then when I'm talking about surgery with them, we address my length of stay, if the patient would be willing to go home. And believe it or not, I'll talk more about my data later on. I have yet to have a patient who said they didn't want to go home. They actually all felt that if my experience is good and if they will be more comfortable at home. As far as there's support available, they can call somebody is available. What other things comes in preoperative for us is we have an hour-long ERAS class. Every patient has to attend a week before surgery. And these are identified by my admin staff and then scheduled for ERAS class, which is run by our ERAS research nurse. We give our patients a kit, which is already made. So as soon as I put colectomy or a colon resection ERAS orders in, the pharmacy starts working on these kits, which include bowel prep, protein shakes, immune shakes, incentive spirometer, container for urine or ostomy effluent with measurements, and ostomy training kit. This is what the kit looks like. So basically, everything has been collected in a kit for a patient to give it to them, so they are ready for their surgery and the prep a week before their surgery. This is Tanya. I couldn't do this same-day colectomy or any colectomy without my ostomy nurse. I'm sorry, ERAS nurse.
And I'm the ERAS coordinator here at Baylor Southwest. And welcome to our ERAS class that we teach all our elective patients about the enhanced recovery after surgery so they can have the best pathway to surgery. Come on in, let's show you what they get. All our patients get an ERAS kit mailed to them if time permitted. So these are our objectives that we go over. We'll go over our pre-op process expectations, nutrition, before and after, rehabilitation, pain management, day of surgery, what to expect post-op, again, ostomy care, and discharge information.
And then additionally, on top of this, when I identify a same-day colectomy patient, that's tagged in my notes. I physically tell Sonia, these patients are going to go home. So there's another layer of reassuring the patients after they've already met with me the week before surgery. This is patient's perspective. How does the patient feel from all the ERAS preparation and going home on same-day colectomy? This is a patient who went home 6 hours after surgery. She is post-op day 2 in the clinic after a sigmoid resection.
Yeah, so sigmoid colon resection, prepared beforehand, had a class with Sonia, very informative, a lot of printout sheets, a lot of information. I was like, oh, ease my nerves enough to get to the hospital the day of surgery. Everything was well explained.
Actually, I misspoke. She was post-op day 1. She looks great. And does this patient need to be in the hospital? She's in her street clothes. She has obviously slept well and doesn't look like she's in pain. Post-op day 1 at 8 o'clock in the clinic. So again, preoperative phase, we kind of get the patients ready. The second thing beyond, actually the most important thing in the patient's mind usually for surgery is my pain going to be under control? So we talk about multimodality pain control, gabapentin, Tylenol, Celebrex, Tramadol, and then we also give them Elvivopan. So the day of surgery comes in, the patient comes in the morning, we do pre-op blood glucose. They're advised to take clears until 2 hours before surgery. They actually take clear protein shake. They are carb loaded and given Entereg, Tylenol, gabapentin, Celebrex in day surgery, and also DDT prophylaxis. Early on in my experience, one patient came back to the ED. So we started now with identifying high risk of postoperative nausea, vomiting. Anesthesia has a high risk postoperative nausea, vomiting calculator. And I usually will have anesthesia place scopolamine patch on all of my same-day colectomy patients just to mitigate the risk of post-op nausea. And we also identify if they're high risk, we'll give them some steroids intraoperatively to prevent nausea vomiting. So intraoperative phase, narcotics are limited by anesthesia, fluids are limited, and steroids are given for anesthesia. We have separate tray for gown gloves for fascial closure. Documentation is done in the records. What does the surgeon do in preparation? So MIS surgery, I do intracorporeal anastomosis. I'm checking perfusion for anastomosis with the IC green and notes extraction and minimizing EBL. We do all of these routinely. So there's nothing I've changed on any of my patients. I was doing notes extraction before I started doing same-day colectomy. So use of technology, and obviously we're in the era of technology. I'm going to talk some about some technology I think I use. Robot is for me easier for me to do ICA, less tension on the mesentery, earlier return to bowel function, decreased length of stay, we've already proved it, less narcotic use, and choice of extraction site. That's really important, especially in obese patients to prevent hernias, small bowel obstructions, and SSIs. So this was 2019. I like to show 2016. I like to show this video, which I could do laparoscopically, but how the robot helps me. And so this is a video of notes extraction I did in 2016 with a transvaginal extraction. I use an EA sizer to identify a vaginotomy site. I'll bring an anvil in through the vagina, and my sutures also come through the vagina, and then passing the anvil into the colon. And then this is a pop-through technique, so the anvil is going to come through the staple line. You can see I can sew laparoscopically. I had an MIS fellowship where I did a lot of colon resections, but my arms are awkward, my shoulders hurt, and this is a very skinny patient. You can see there's no fat in the background. What if this patient was 350 pounds? Then it's going to be really hard for me to do this intracorporeally. I'm just removing the spike and then ready for anastomosis. The specimen actually was removed from the vagina, but am I going to be able to do this with this patient? Not only I'll have lots of torquing on the abdominal wall, my shoulders are going to hurt. Surgeons are like professional athletes. We have to preserve our bodies. We don't get to retire at 40. We have to continue working. And so I am all for using technology to help us increase our career length. These are some pictures of the incisions moving around. The first one is an ultra low anterior section in a 38-year-old male with a suprapubic extraction. And for rectal cancers, I do not extract from rectum just because I want to maintain the integrity of my TME. He went home 6 hours after surgery. He actually had come to see me from 3 hours away, and he was excited to go home. And when I followed up with him next day, he had slept well, he had great recovery, and he would do it again. This is a BMI 48 with a suprapubic extraction, BMI of 42 with nose extraction. Actually, the lower suprapubic incision, actually it was just drawn, but we never used it because we did a vaginal extraction. This is a colostomy takedown. This was another one of my 6 hours of lysis adhesions, and he was able to go home 6 hours after surgery. A 3-port robotic right with the smallest incision you can have. No reason to stay in the hospital for pain control, at least. And now I've moved to suprapubic rights with all the incisions below the bikini line for even less disruption to the abdominal wall. This is a total colectomy. And a lady who had TAH-BSO, and the total colectomy was for Lynch syndrome, and she had an ileorectal and discharged home in actually 10 hours. This is another one of suprapubic, nodes extraction. You can see where it's marked below. That's what we had initially planned to remove, but we decided to proceed with a transvaginal extraction. This is one of another patient's 82-year-old who actually had 2 organ surgeries. He had a partial gastrectomy as well as a right colectomy from the suprapubic ports. He stayed in the hospital for 2 days because he's 82 and on a wheelchair, but you can see with the incisions how you can minimize pain when the incisions are not on the abdominal wall. This is a specimen 6 centimeters gist, which was removed along with right colon. You have tons of pictures. We're going to move through these. So with the robotic technique, and it doesn't matter which robot you use, variety of anastomotic techniques are available. Wristed instruments help with suturing. Roll of IC green can help with segmental resection when I inject subserosely. Extraction site, for me, that's the most important criteria. I can choose where I extract from, which helps with pain control and recovery. Another thing I use in technology is air seal. So if you notice in the beginning of my incisions, I had an assist port. I have removed the assist port for low anterior sections or even rights because I placed my air seal, which is sustained pressure through the robotic ports now. And the advantage of that is you being able to operate at lower pressures. So I operate at 7 to 10, the pressure of 7 to 10, which has shown to decrease preload, increases your kidney function, as well as decreases bowel edema. So this you can see the purple top on the right port, the first right port, where the air seal goes on to the robotic ports. Tap lock. So at my institute, the tap lock is given by the anesthesiologist's APMS service afterwards. Try to get it before and as first thing, but then it's going to delay my start, so I prefer to get it done afterwards. Tap lock has been shown to be more effective if you give it before the incision, after the first incision, before the rest of the incisions are made. The surgeon can give it, or a PMS service can give it. Foley, I remove Foley in the operating room before the patient wakes up, unless low anastomosis. Now, one trick I learned from Leila Rashidi is backfilling the bladder with 300 cc's before removing the Foley catheter, which ensures the patient has voided once they get to PACU. What we do in recovery, so early oral feeding, my patients, as soon as they're awake in the recovery, they are given full liquids. They are given puddings or yogurts, which is tolerated immediately. I think clears are not tolerated well by patients after anesthesia. The jellos and broths are sickening. Even if I keep the patients in the hospital, I always start with full liquids. And then they're observed for nausea, vomiting. They're also ambulated in PACU after 2 hours. A couple of weeks ago, I had a patient who went home 2.5 hours after surgery. By the time she left recovery to same day. She'd already walked in the recovery from her bed to the restroom and walked around, a lap around the recovery. So early ambulation in PACU is important. Now for that, you do need buy-in from PACU staff, but our PACU staff is used to my same day colectomy patients because that's communicated in the morning. Again, in the morning with anesthesia staff, the nursing staff, or PACU staff, everybody knows this is the same day surgery patient who's going to go home today. So discharge from same day surgery. The first patient, the very first patient, I checked labs prior to discharge. Now I don't do that. Checking if their vitals are stable in the recovery, I don't have any reason to check the labs. And BMP honestly is not going to help me at all. Another dose of DVT prophylaxis is given to cancer patients. My criteria for same-day colectomy patient is that these patients are all seen by me prior to discharge. We give them a PAN nurse number, and most of them, are given next day appointment, in-person appointment. Now, I do have patients who come from 3-4 hours away. Those are the patients I will call or do a video visit next morning. And then rest of the week, they get video visits or phone calls with our ERAS nurse. I don't push diet on these patients, especially regular diets. We tend to do that when we keep them in the hospital because we want them to leave. I tend to just let them continue protein shakes and full liquids until they're comfortable, and they're told to advance diet whenever they feel comfortable with what they want to eat. So, use of technology. Again, we're in the era of internet, smart watches, smart trackers for a little bit of time, and I don't endorse this technology, but we use the vital sign tracker at home, which track their heart rate, O2 saturation, blood pressure, temperature. It was sent to an app on a smartphone. It looks like basically like an Apple Watch with a pulse ox attached to it. And the pressure sensor goes on the chest wall. I'm sorry, not pressure sensor, temperature sensor. And the data is then sent to secure services, and it has built-in triggers to notify for preset changes in vitals. This is what it looks like. Now, this technology was used in California during COVID times to send COVID patients home 2 days early because of COVID surge, and they didn't have any beds. And what you're seeing in the monitor the physician is looking at is what they had our command center, where all these patients with their trackers were actually transmitted to their clinical portal, and a physician or a provider was able to look at their vital signs and keep monitoring them. This is setting up the safety net device in the recovery. This is one of my younger patients who had a colostomy takedown, and she is again, all these videos are shared with patient permission. This one of my residents, Dr. Ollinger, is setting up the vital sign trackers, and you will see at the end of this when she shows you the app what her heart rate and pressure, saturation looks like, which are completely stable, and this patient does not need to be monitored in the hospital.
Tracker.
So he's putting the temperature sensor on her chest wall. She already has the vital signs tracker and the pulse ox on her finger.
That starts showing your vital stuff here.
We can see her heart rate is 80 and her pulse ox is 100. At her age, there's no reason to be in the hospital. So some of my data now, characteristics of my patients. So far from December 2020 to now, I have done 64 prospective planned same-day colectomies. This is all single surgeon experience. I'm the only one in my health system who does this. Average BMI was 28, but I've operated on, actually I haven't updated that, but up to BMI 48. So I don't have a cutoff. As far as, I think the cutoff for me is basically the patient's mental and buy-in. That's the biggest cutoff. There's not much difference between males and females. Average age is 56. The oldest one I've done is 77 because she was a very good 77. She looked like she was in her 50s. The diagnosis is also across the board. The rectal cancers, the one I include are the upper rectal cancer or mid rectal cancer when I do upfront LAR without a diverting ileostomy. So my average length of stay now is 10 hours. All these patients are advised right after, before I see them, when I see them in day surgery, and if I ask them this question again, would you like to go home or would you like to stay? And most of them, because they're mentally prepared, not most of them, actually 100% of them, nobody has yet to say, I would like to stay. They all want to go home. A few weeks ago, I had a patient who had colovaginal fistula and ultra low anterior section with the flap and vaginal repair. And I felt a little iffy and I said, maybe you should stay tonight. And she said, no, I'm good. I'm gonna go home. She was from 3 hours away. She drove back 3 hours because she was mentally prepared. I spoke to her next morning and she was out in the neighborhood walking around the block. So far, 0 complications. And again, it's not the product of my surgery, it's a product of, these are very highly selected patients. And I've had one readmission, which was 14 days after surgery. And this was recently too, and he was readmitted with C. diff. I don't think I could have prevented that in a patient who went home 2 days after surgery. So it is a readmission, but really no different than if the patient was in the hospital. And average surgery time was 188 minutes. And again, the surgeries are all across the board. I don't send total colectomies home on same day. So 2 days ago, very exciting. SAGES has an official publication on same day discharge following elective minimally invasive colorectal surgery. And the conclusion was that the SAGES colorectal community has performed a comprehensive review of the early experience with same day. And it summarizes early results and consideration for safe and stepwise implementation of same-day colectomy. Patient selection, again, is the most important. Remote monitoring, or you can use a tracker, vital signs tracker. You can you can have an app, or you can call them yourself for a video-based assessment on these patients. So there we have it, officially from SAGES endorsing same-day colectomy, and again, highly selected patients, and if you have infrastructure available. So what about reimbursement? We know it's in the back of everybody's mind. Are we going to get paid, or are we going to get paid as same-day colectomy? This is an article from JAMA Surgery in 2016, which talks about bundle payments for surgical colectomy among Medicare enrolling. So mean risk-adjusted hospital colon resection fixed is 10,000, averaging between 7,000 to 17,000, and variable cost is 14,000, averaging from 9,000 to 22,000. And total median cost is 24,000, averaging from the range from 16,000 to almost 39,000. Oh, I'm missing a slide. Sorry. So there's a slide I'm missing, I don't know why, which talks about, let me see if I have it here. No. Here, this is the one. So total inpatient costs by diagnosis related group. And what happens when you, based on this, if you have observed versus expected length of stay. So if the expected length of stay is, observed length of stay is more than expected length of stay, even by a day, the hospital actually loses the cost. So the median cost of the hospital actually is twofold. So the hospital reimbursement actually goes down by half when a patient stays 1 day extra than expected. And I'll go back to these slides. No, sorry. I don't know why my slides are off. So DRG for colon resection, 36,000 to 40,000. Cost of 1 day of hospital, we don't know. It's hard to get that data. I use inpatient codes for these patients. They're admitted and discharged. So the reimbursement has, for now, is the same. For me, the cost saving is saving of resources, reallocation of resources. availability of beds for sicker patients. So patient expectations, we all talk about what is the patient's concern, their expectations, their satisfaction. These are a couple of videos which talks about how they feel.
And how do you feel about going home today?
I feel good. I got the shot on the belly, so I'm a little sore, but I feel good.
Are you apprehensive at all going home this early after surgery?
It's a new thing, but I mean, it's definitely, I mean, it's cool and you get to heal at home where you're comfortable, you're not around, you know, in a hospital where sometimes it can be a little nerve wracking, but no, yeah, I mean, I feel good about it.
Okay.
Pretty easy.
And so far with your experience, do you think if you had to do it all over again, would you do it again?
Absolutely.
This was a patient who was in the recovery 4 hours after her colostomy takedown. This I call my case control. So the lady on the right, she had a low anterior resection with me for rectal cancer 3 years ago, and then her husband had surgery with me as part of my same-day colectomy. And you'll hear what their experience is with this whole process.
I had colorectal surgery 3 years ago, and my husband had it 2 days ago. And the difference between, I had to stay in the hospital for 3 days, and watching the difference of him going in, having day surgery, and coming out and going home, it is a huge difference. And it makes a whole lot better recovery with him being able to go home and do it himself.
Pass these slides because they were out of order. So what have I learned, my lessons are from this whole process from December 2020 to now? The same-day colectomy or the ERAS protocol has to be patient-centric. Obviously, without the patient buy-in, this cannot be successful. If our patients are they have independent minds, and we can't stop them from coming to the ED, or we can't prevent complications. But if they are mentally prepared, they're more likely to actually do well at home. ERAS infrastructure is very important. So doing this at this point is not for everybody. Early on in their colorectal experience is not for everybody. I would say if you're embarking upon decreasing your length of stay, you start with ERAS protocol, standardize it, look at your outcomes and see how you can slowly improve them. And then obviously you can't graduate from fellowship and tomorrow I'm going to start sending patients home. It's not going to work. Use of technology. We're in the era of technology. We should use it to our advantage. Where there are things I may not be aware of, which are out there, and the younger generation is really good at technology. And then early post-op visits are important. We're sending these patients home, but I call them or see them next morning. So Mark Solomon, when he heard about this, he said, it's basically like they're coming to make rounds with you as opposed to you going to make rounds on them. And then it's all about changing the paradigm. When I was a resident, we were sending them home 7 to 11 days after surgery. Then we started sending them sooner and sooner. Last few years, I started sending them home within 24 hours, but without actually consciously making that decision. And now I've changed it to when I talk to these patients. So in conclusion, same-day colectomy is feasible in highly selected patients. I cannot emphasize that enough. Not every patient will go home, and not every patient is going to thrive at home. Extensive infrastructure for ERAS is extremely important for success. Early post-op discharge follow-up is very essential for these patients. And I'll leave you with my favorite patient who talks about his experience a year and a half from when he was my patient 0.
All righty, I'm Calvin Smith. I had my surgery at the height of COVID. Basically, I was diagnosed with a colorectal tumor, and I went into the hospital, had my surgery. I had it as an outpatient. There were issues with beds, and there were COVID patients that needed my bed. So as a result, my surgeon and I made the determination that I would have it as an outpatient. I had my brother with me who helped me out. Had the surgery, went across the street from the hospital, stayed in a hotel there overnight, went back the next day.
How did you feel going home 6 hours after surgery?
I had no problems with it. Given a choice, I would have done it again via hotel with the catheter. I wasn't, I wasn't best pleased with it, given a choice, but I just had surgery, and so it's just something that I did. I wasn't particularly apprehensive about it, and I'm sure that the hospital or the hotel had seen that kind of thing before, given that they're right across from the hospital.
And you had your second surgery and you went home, actually straight home after that, when the ostomy was reversed.
Yes.
And you had gone through the previous one, going across the street to the hotel. Did you feel more confident after?
The first surgery really went extremely well as far as I was concerned. No ill effects, very little pain after the fact, and so I saw no reason why the reversal would be any different. I went about my normal routine. I mean, I play basketball, and I was playing basketball with an ostomy bag. And the people that I was playing ball with were friends of mine. They didn't know that up until I told them. So.
And if you had to do it all over again, would you
Oh,
consider it
absolutely.
again?
I mean, given a choice between the way I did it and possibly staying in the hospital for 3 days, I'd much prefer doing it the way I did.
And when we talked about it, doing the first surgery as outpatient, we were facing delaying your surgery. How did you feel?
I didn't want to delay the surgery. If I'm not mistaken, I'd already pushed it back one time, and the delay was based on a surge of COVID.
And that's it. Thank you, and I'll take questions.
All right, thank you very much, Dr. Essani. That was wonderful, and I thought you balanced the patient selection and ERAS aspects very well with utilizing technology and getting support from all areas in order to achieve this really cool goal. I wanted to summarize a few things that have been going on in the surgeon side of things. Doctors Solomon, Rashidi, and Marinez have been chatting a bunch, so I highly encourage anyone who's on the Zoom call and not on Surgeon to take a peek at that later. Kind of the too long don't read is that both Dr. Rashidi and Dr. Marinez have had similar rates in terms of how selected they are for their patients. Dr. Rashidi says she gets about 25 to 30% of her colons as same-day patients, mainly small bowel resections and ileostomy reversals, whereas Dr. Marinez is about 40% of actual same day, and that increases to 60% for the patients who go home before 24 hours after surgery. They both talked about having to have multiple conversations with administration as well as all the PACU staff in order to get buy-in from everyone to really make this successful. We also have a couple questions from Dr. Lee. She is wondering if you do transvaginal extraction for right colectomies, and also if this can be done for diverticular disease.
So I don't do transvaginal extractions for right colectomy because I do all my ports suprapubic now. And then, I just merge a couple of ports in the midline to do the extraction. And but there's a surgeon in Australia, Philip Scan, who actually does them laparoscopically and extracts transvaginally. I haven't had any trouble getting my patients to agree to transvaginal extraction for any case. I've never had anybody turn me down. I just don't think that with my suprapubic ports I could do transvaginal extraction because it'd be hard to kind of sew the vaginal vaginotomy. Now for diverticular disease, I do if they're women, I always do transvaginal. It doesn't matter cancer or diverticulitis. For rectal cancers, I will also extract from vagina. especially if I'm doing a combo case with gynonc for if it's TLHBSO, something like that. And even if it's not, I will still extract from vaginotomy in women. 100% of my patients agree to it. Now, for men, for diverticular disease, yes, I do. And, I've looked at Eric Haas's technique, or what I call chicken stripping the colon. You can, if the colon is really thick and fibrotic, that's the main reason you can't get this out. Specimen through the rectum. So I just make tiny little strips out of the colon, just cut it to remove it.
Very cool. One question that I had is, as a fellow who will be graduating in about 10 months now, if I go to a place that does not have a robust ERAS program set up, what are some pearls that you have in terms of initial steps or ways to approach it to really get buy-in from everyone?
So I think in preparation for graduation and starting your first job, I would start looking at other surgeons' ERAS protocols. Social media and the sharing we have on our groups. You can easily actually kind of look at a lot of surgeons' ERAS protocol and pick what you like or what you will have availability. I think tab blocks, protein shakes, those are really easy too. And then have it written down. And then when you are at your hospital, you talk to your office staff. Even if you don't have an ERAS nurse, you can have your office staff kind of come up with it's very easy to make a little handout for patients and talk about how you want them to go do things, and then talk to anesthesia about doing a tab block, talk to pharmacy about incorporating protein shakes, or and then Entereg is universally used. And with decreasing the narcotics, we are already all working on using gabapentin and multimodality pain control. So in essence, like besides patient education aspect of it, a lot of it is very intuitive, and you can start to standardize protocol. That's what I would recommend, is every single one of your patients should go through the same protocol, and then kind of look at your length of stay and see if you can translate it to same-day colectomy in a year or two.
Thank you. I see Dr. Walker has a hand up, so I'm going to let him unmute himself.
Dr. Essani, I'm 100% on your side, and I'm heading towards your way. There was a couple Twitter posts right before your talk from Drs. Bastaros and Friel going back and forth with the poll regarding insurers versus hospital versus patient versus surgeon. Who do you think benefits the most? What is your response to that?
I think the surgeon definitely doesn't benefit. I have more anxiety, more stress, and it's more work for me. I mean, I have to call these patients the next day, and all of my patients, I call every single myself, despite my ERAS nurse doing it too, but I need to know how they're doing. I see them before they go home too, so that extra work for me as well. But the hospital does benefit as of now, because we are getting, the reimbursement is the same because we're using the inpatient code. The patients do benefit. And if I don't know about everybody else's practice, I've started seeing younger patients in their 20s and 30s. I've operated on more 30-year-old with colon and rectal cancer in the last year or two than ever before. So our patient population is getting younger. And so is there a reason to keep them in the hospital? If the surgery went beautifully and you didn't have any, and you have controlled all the factors, I don't think the patient has to stay in the hospital. The benefit are we going to see is from the population growth in every city. Austin has grown immensely. All the cities I'm seeing, there's a huge, we're going to have hospital shortage. We're going to have hospital bed shortage. So we have to start working towards some of these procedures we can make outpatient to make beds for the sicker patients, or we're already seeing nursing shortage and all the staff shortage. I don't know if it started with COVID or if COVID was just the tip of the iceberg, but we're going to have shortage of staff as well. So why not work towards a reallocation of our assets too?
Do you see an issue with insurers starting to require same-day surgeries? I mean, I do a side hustle where I review reports, and some of the questions that come up are, does this patient require the length of stay that the surgeon asked?
Well,
And
so
to say, oh,
so
you
for
know,
now, low anterior section, colon resections, they are in patient codes 44207. Until those codes change, I don't foresee that they're going to require. And if you look at it, as I mentioned, and my patient population was all colon resections in this study, is it because 10% can be sent home, it does not mean the other 90% can go home. So unless we can say that we are going to have 60% of our patient population going home, the code is not going to change. There is only a highly selected group of patients who are going home. The rest of them are still in their 60s, 70s, unhealthy with high morbid conditions, comorbid conditions. They can't go home.
Thank you. There's another question from Dr. Lee on Surgeon, and she's wondering what the difference is in your rate for same-day discharge for diverticular disease versus cancer.
No difference. I mean, for the same day?
Yeah.
Actually, there's no difference in my based on diagnosis. They all go home within 6 to 8 hours. There's some I would keep overnight if I not overnight, but if I got done at 8 p.m., I cannot send them home at 2 in the morning, so they go home at 6 in the morning. But I have not seen a difference in terms of diagnosis leading to increase or decrease length of stay.
Thank you. 2 final comments from Surgeon, and then I think we'll wrap up. Dr. Solomon wanted to point out that there is a transvaginal extraction webinar that Dr. Essani and Dr. Shanker did on Surgeon a few months ago, so check that out if you're interested. And finally, Dr. Rashidi and Dr. Marinez on Surgeon posted their inclusion and exclusion criteria too, so that there's you can see everyone's what they're using. So thank you so much, everyone, for joining us tonight. We'll be posting these videos later this week. And thank you again for Dr. Essani and all your preparation and your talk.
Thank you for inviting me.
Have a good night, everyone.
You too.